Hello, once again, this is Professor Crawford, and I am going through part 2 of shock, and this is the final part. Once again, let me set my timer here, and we'll get started right now. Now, I am going to go through the stages of shock, and there are 3 distinct stages of shock that you'll need to look out for. The first type is the compensatory stage. Here, once again, we're looking at equilibrium, homeostasis. Here, there's a loss in blood volume, so the body just doesn't accept that. It responds with different types of neurons, neurological system, different hormones, biochemical compensations to overcome this major hypotensive state of shock. And the goal is to maintain that balance, and this compensatory state gives us a little opportunity to resolve whatever problem it is that caused the state of shock. The way the body compensates is that the sympathetic nervous system is activated, so the blood vessels will be constricted, and we have a release of some very important catecholamines. Epinephrine and norepinephrine will be released so that they will help to constrict the blood vessels. Therefore, the blood pressure will go up. And not only that, epinephrine, norepinephrine, the vasopressors, the catecholamines will help the heart in terms of beating stronger. It's going to increase myocardial contractility. And that is what the patients need. They need the heart to beat harder, faster, and they need that blood pressure to go up. Also, we will see activation of the renin-angiotensin system, where we have antidiuretic hormone, aldosterone release to reserve sodium and to hold in water because of that state. Consequently, for a little bit of time, we'll see like a drop in the urinary output because the body is holding back and reserving fluid. The second stage is the progressive stage, and this is bad. By this time, hopefully the problem will be resolved. But here, this is when the compensatory mechanisms begin to fail. The patient's general condition will definitely deteriorate at this point. And the body systems will show signs and symptoms of that deterioration. If you turn to table 67.7 or 67.6, all 3 stages are identified, and you can see how the major body systems respond in each stage. Once again, we often see hypotension in the progressive stage, a very rapid pulse rate. We'll see tachycardia. It's probably not in neurogenic shock because you'll see bradycardia there. But the skin is going to be very cold and clammy. Hypothermia may set in. Whenever you see hypothermia, that is very, very bad news. That is an indication where the body is kind of shutting down. When I worked in the burn intensive care unit, when we were treating patients in septic shock, we were doing everything we could, but if it got to the point where we saw the patients become hypothermic, like 97, 95, we knew that was a very grave sign, and it is a very poor prognosis at that point. And then finally, we have the irreversible stage, also known as the refractory stage. Here we're going to see profound hypotension. Also hypoxia, so make sure that you're reviewing your arterial blood gas results. And also when you look at Lewis, you'll see how all the major body systems are going to be in failure. Unfortunately, this is a very grave stage. It's the final stage, and recovery is unlikely. So you really have to make sure that I help to look at those assessments, look at the patient's response, and do a whole lot of nursing interventions in the compensatory stage before you get to that final stage, because it is it's not likely to be reversed. Are there any diagnostic studies that we can do to see if a patient is in shock? No, there is not one single diagnostic criteria or study to see if a patient is in shock. We need to look at the history. We need to find out, was the patient in an automobile accident? Did they have major burns? Did they go for surgery? Are they having hemorrhage? That assessment is important. That history is important. You've gone through physical assessment, so you know how to assess a patient from head to toe, because that information is going to give you valuable data if the patient is in shock. Now, in terms of treatment, again, pull out this handout that I prepared for you guys, because this is going through the medical surgical interventions. Always remember, you have to go back to Maslow's hierarchy of needs. Do the ABCs, airway, breathing, and circulation. The patient is shocked. Remember, they're not getting oxygen delivered to those vital organs, so they have to be placed on 100% oxygen. Make sure that they're breathing. Circulation is important. How do we do circulation? We have to do fluid resuscitation in these patients. They don't have circulating blood volume. We don't play around. They have to receive isotonic solution. The isotonic solution is going to be normal saline solution or lactated ringers. You can't just use a little skinny IV catheter. You have to use 2 large bore catheters into the antecubital space, the big veins, to deliver those that isotonic crystalloid solution. Because we do have to quickly manage hypovolemia. So you have to use those large bore angiocaths. And you have to deliver that fluid. Make sure that you evaluate for any consequences of hypovolemia. Is the patient getting too much fluid? So you have to make sure you have your stethoscope and check those breath sounds. Drug therapy is important. We have to give these patients vasopressors, usually epinephrine, norepinephrine, to constrict those blood vessels and get that blood pressure back up. Before you give those pressors, you make sure that those patients are very well resuscitated, that they are well hydrated. No sense in constricting those blood vessels if they don't have any fluid. So these patients have to be well hydrated and go through resuscitation, fluid resuscitation. You also have to monitor the blood pressure and the heart rate. And you know what, with those pressors, they are definitely going to get that blood pressure up. So you have to titrate it. So you have to titrate and get the blood pressure down. So you make some adjustments. You never abruptly stop those pressors. If not, the patient will become hemodynamically unstable. So we wean them off of those pressors until the patient is able to adjust and adapt. So monitor the patient, wean them off slowly, and look at those vital signs. Nutritional therapy is important. Remember, when they're in shock, they're not getting those vital nutritions to those cells, so we have to give them nutrition. And that will occur 24 hours after shock. So they'll need nutritional supplement. We don't want them to become catabolic. So usually they will give them supplemental feedings if the gut is working, or TPN. So that's going to be important. And then we have to do ongoing monitoring. Look at the patient's neurological status. Look at the patient's cardiovascular status. Whenever a patient, if it's a post-op patient and they're going into shock, you're looking at their blood pressure, you have to put that patient in a situation where you can have blood return to the vital body organs. So the way we do that is we elevate the feet. We put the patient in a modified Trendelenburg position where we can get a pretty good blood flow back to the vital organs. And shock, something that's going to happen is that mainly the vital body organs are going to be perfused. So there will be a shunting away of blood flow from the skin, from the stomach, from the gut, from the kidneys, and that blood will go to the brain and to the heart. Those are the vital organs. So we can really help that process and help the other organs by elevating the feet in a modified Trendelenburg position, and you do that in a medical surgical area. The respiratory assessments are important. What if the patient is having a backup of fluid in the lungs? So you have to have those stethoscopes. Look at the urinary output, because when you're giving a lot of fluid to the patient, I and O, we got to see a good output, because if we don't, we know that the patient is going into renal failure. You're giving a lot of fluids, so we have to have some good, clear urine output coming back. If not, we know that the patient more than likely will be in the progressive stage of shock. Check the body temperature. Remember, when the patient's temperature becomes hypothermic, more than likely they're going into that progressive stage, and we need to catch that and report that to make sure we can perfuse the patient better. Check the GI status of the patient. Check those bowel sounds. The bowels will be affected. Personal hygiene is going to be important. Those patients are not going to be able to move about. They're going to be bed-bound, so we got to give good skin care and take real good care of those patients. And don't forget about the emotional support. There's a lot of things that are going to be going on with these patients. So we have to make sure they get rest. We have to take care of the family. We have to stay in contact with them. We have to reassure the patient, take good care of them, get their cooperation, and the whole bit. So at this point, make sure that you look at pages 1729, because Lewis covers the interventions beautifully. The chapter is not long. So they talk about the large bore IVs. They talk about using the pressors, safety, using the sympathomimetic drugs, those pressors to get the blood pressure up. They also, on page 1732, she identified those important pressors that you'll be giving the patients to get those blood pressures up and the expected responses. Nutritional therapy is covered as well. And also she talks about the treatment for each type of shock and the importance of the nursing assessment for our patients. Looking at the urinary output, she also goes through the output, and here she has, like, if the output is 0.5 mLs per kg per hour, that's inadequate perfusion, and the patient more than likely will be going into renal failure, so we got to keep an eye out for that urinary output. I'm not going through systemic inflammatory or multiple organ dysfunction, because that's beyond the scope of medical surgical care of patients with shock. So that's pretty much it, you guys. Hopefully you enjoyed this YouTube video. And make sure you go through Lewis. She covers it beautifully. And that's pretty much all that I needed to cover. So thank you all for your attention. Have a nice day. Bye.